Hi, my name is Douglas McLean. I am a surgical technology student at in microbiology class at CBD College. Today I'm talking to you about history of Ebola. Ebola virus is considered a fluorovirus, single-strand ribonucleic acid virus. It was first identified in 1967 in an outbreak in Africa. 25 people working with monkeys were infected and sickened with aggressive form of hemorrhage fever. In 1967, the strand was coined Marlboro hemorrhage fever. A second case of Marlboro fever was identified in 1976 in Zimbabwe. First reported outbreak of what is known to be Ebola was identified in 1976. 318 people became ill in the region of Zaire, known as the Republic of Congo, where Ebola River is located at. Concurrent outbreak in neighboring Sudan sickened 284 people. Analysis of Zaire and Sudan outbreaks determined they were two different strands of what we know as the Ebola virus. Investigators had a hard time identifying the source of infection, natural host, and routes of transmission. Recent research suggests that some species of bats may serve as a natural reservoir for fluoroviruses. On this slide, we see the Ebola virus under a microscope. Symptoms of Ebola may appear anywhere from 2 to 21 days after exposure to Ebola. Symptomatic Ebola are nonspecific and may appear similar to influenza. These symptoms are also consistent with many viral prodromal phases of infection. They include Malaysia, joint and muscle aches, nausea, vomiting, headaches, and diarrhea. Symptoms of Ebola are fever, severe headaches, muscle pain, weakness, fatigue, diarrhea, vomiting, abdominal stomach pain, unexplained hemorrhaging, bleeding, or bruising. In this slide, we see a picture of hemorrhaging of a child. In this slide, we see the phases of fever between the 7th and 12th days of infection and the aches and pains that follow. Diagnosis of Ebola require clinicians to rule out more common elements, including influenza, malaria, and dengue. A patient with Ebola is not considered to be infectious until he or she starts to show signs of symptoms such as fever. Prompt recognition of symptoms, coupled with a thorough travel and contact history, is critical in ensuring early isolation of infected patients. Concurring guidelines recommend screening any patient presenting with a fever or more than 100.4 degrees Fahrenheit for a travel history within the prior 3 weeks to areas with endemic Ebola. A patient with a positive travel history and with an elevated temperature should be isolated pending further evaluation. Infected patients should have a private room with a private restroom and doors should be closed. In this slide, we see the room for a patient that's isolated with the Ebola virus. In this slide, we see a diagnostic procedures of how they test the blood for an infective Ebola patient and a special transportation for laboratory specimens for Ebola testing. The risks of exposure and likelihood of infection. It is shown that healthcare providers caring for Ebola patients and family and friends in close contact with Ebola patients are at high risk of exposure. Coming in contact with infected wildlife, wild animals hunted for food, and contact with infected bats. The virus also can be spread through contact with objects like clothes, bedding, needles, syringes, sharp, or medical equipment that have been contaminated with the virus. Direct physical contact with an infected patient, Ebola virus can stay in semen and in vaginal fluids even after recovery. In this slide, we see who's most at risk of being infected with Ebola virus. The likelihood of infection. There has been no evidence that a single household contact who did not have direct physical contact with Ebola patient has then subsequently contacted the virus. In the United States, the risk of exposure to the Ebola virus is very low, and the risk of infection from caring for a patient with Ebola is extremely low. Using PPE, personal protective equipment, helps with maintaining a low risk factor. We stop.